Welcome to this explainer. If you work in a medical practice, just hearing the words prior authorization probably makes your blood pressure spike, right? It is literally the only process where you'll wait 45 minutes on hold, listening to terrible elevator jazz just to be told to send a fax in the year 2025. It's an absolutely universal frustration, and it often feels like a giant maze designed specifically to keep you and your patients just running in circles. Well, today we're going to untangle that maze. We're going on a journey from absolute administrative chaos to streamlined clarity. We're going to look at exactly why prior authorizations get delayed, and more importantly, how to actually fix those bottlenecks right at their source. Let's start with a foundational definition of what a prior authorization is actually supposed to be. In its ideal state, it's really just a smooth administrative checkpoint. It's meant to be this straightforward pause to simply confirm medical necessity before a service is rendered. It shouldn't be a battle. It should just be a quick, standard verification step on the way to delivering patient care. Okay, let's dive into this reality check. On one side, we have that ideal checkpoint. Smooth, quick, and clear. But on the other side, we have the reality that most practices actually face. The choke point. This is the exasperating daily grind of your staff just aggressively refreshing payer portals, navigating endless waits, battling severe EHR workflow friction, dealing with dropped peer-to-peer calls, and staring at cases that are just stuck in review while patients anxiously wait for their surgery or imaging or vital medication. To truly grasp the massive scale of this choke point, look at this staggering number from the American Medical Association's 2025 Prior Authorization Physician Survey. 95%. 95% of physicians explicitly state that prior authorizations delay access to necessary care. Think about that for a second. That is nearly every single doctor surveyed pointing to this exact administrative process as a direct, tangible barrier to patient health. And the fallout from those delays? It's literally devastating. According to that same AMA survey, 79% of physicians report that patients completely abandon their treatment because of these exact delays. Nearly 8 out of 10 doctors have seen their patients just give up on getting better simply because the administrative labyrinth was way too exhausting to navigate. So here is our blueprint for today's explainer. First, 1, the real bottleneck is upstream. Second, 2, the 7 major bottlenecks. Third, 3, the ticking regulatory clock. And finally, 4, fixing the 4 zones. Let's get right into it.
Part 1. The real bottleneck is upstream. It's not just the payer. Now yes, rising case volumes and aggressive payer policies are very, very real. But volume alone just doesn't explain why one practice clears an auth in 2 days, while another practice down the street waits 3 weeks for the exact same request. The uncomfortable truth here is that the primary blockages are often happening right upstream, directly on the medical practice's own desk. To put this into perspective, let's look at the breakdown of a nearly 1,200 case sample study from Data Matrix. The numbers here are staggering. 59% were denied because clinical criteria were not met, 26% were deemed not medically necessary, and 15% fell into both categories. So, what's the big takeaway? A full 100% of these sample denials trace back directly to clinical judgment calls and how they were documented. These aren't just random unfair payer rejections. They're actual communication and documentation breakdowns on the practice side. And that brings us to a huge guiding principle for our entire walkthrough today. Finding where those breakdowns occur and fixing them at the source is the real path to medical practice efficiency. If we really want to speed up prior authorizations, we've got to look internally first and fortify our own clinical workflows way before we ever hit that submit button. Part 2. The 7 major bottlenecks. A workflow walkthrough. Let's trace a prior authorization request from the very beginning of a patient encounter all the way through to the back office, so we can identify exactly where that friction happens. The first 2 traps happen almost immediately. Step 1 is incomplete clinical documentation. So often, clinical notes skip the objective exam findings. They miss the functional impact, or they leave out the conservative treatment history. A reviewer looking at that chart cold simply can't approve it if the evidence isn't actually written down. Step 2 is that there's no single owner. You've got the front desk, schedulers, and clinical staff all touching the case, and because ownership is split and handoffs between departments get messy, the request easily just falls right through the cracks between submission and follow-up. Then we hit the trap of the payer portals. Seeing no auth required in a portal absolutely does not guarantee coverage. It usually just means no pre-service review applies to that specific code and date. Plus, payer criteria shift completely silently.
Take United Healthcare's criteria for a total hip replacement, for example. It defers to interqual guidelines, which actually call for X-rays, not MRIs, as the primary imaging standard. If your front desk just assumes an MRI is fine because, hey, another payer required it last month, that perfectly valid case will get denied for medical necessity even if the portal said it was clear to submit.
Now, what's really interesting about this slide is the sheer absurdity of the peer-to-peer review process that's supposed to fix these denials. According to the AMA, only 24% of physicians say denials are consistently reviewed by an appropriately qualified clinician. And it gets worse. Only 16% say the health plan rep on the phone actually has the right expertise. You are literally scheduling calls to argue complex specialty medicine with a representative who likely has zero background in your medical specialty. It's a massive, massive source of delay.
Concluding our list of bottlenecks, we have the sheer friction of execution. Staff are constantly juggling manual, portal-by-portal submissions, battling really clunky EHR interfaces, and navigating 10 different payer websites, fax lines, and phone trees, which just entirely destroys consistency. Finally, a lot of practices treat denials as dead ends instead of incredibly valuable data. If a denial is just appealed once and then ignored, the practice fails to run a root cause analysis, basically guaranteeing they're going to repeat the exact same mistake tomorrow.
Part 3. The ticking regulatory clock. Automation alone won't save you. We really cannot afford to just sit on these manual workflow bottlenecks much longer because massive regulatory shifts are actively rolling out, and I promise you, simply buying an automation tool is not going to be enough to save you.
The pressure is seriously mounting here. In January 2026, the CMS WISR model launched in 6 states, layering prior auth or prepayment reviews right onto traditional Medicare for specific services. And looking ahead to January 2027, the CMS-057-F electronic mandate takes effect. Now, while these do push for electronic interoperability, you have to remember, automation can shoot a request to a portal in seconds, for sure. But automation cannot write a detailed clinical chart note for you. It cannot capture a patient's conservative care history, and it definitely cannot participate in a peer-to-peer call.
Part 4. Fixing the 4 practice zones, the whole practice approach. So how do we actually escape the choke point? Well, we have to stop treating prior authorizations as just some back-office billing queue, and instead empower the entire practice to take ownership across all 4 operational zones.
Here's that comprehensive 4 zones defense. In the front office, you need rigorous eligibility verification right at intake to catch those requirements early. In the clinical zone, doctors absolutely must capture functional impact and conservative care history in real time during the encounter, so the documentation is just rock solid. In the back office, you've got to centralize submission tracking so one specific owner monitors that case from start to finish. And in the rev cycle zone, you must track denial patterns by their root cause to constantly refine your workflows. By streamlining these exact handoffs between the front office, clinical staff, and billing, practice has massively reduced their admin burden and can actually achieve those incredible sub-1% denial rate benchmarks we talked about earlier.
I want to leave you with this final provocative thought. A prior authorization workflow truly only moves as fast as its weakest link. So, I want you to look critically at your own operations today. Which zone in your practice is slowing you down? Is it your front desk intake, your clinical documentation, maybe your back office tracking, or your revenue cycle analysis? Find that weak link, fix it right at the source, and take back control of your practice and your patient's care. Thanks so much for joining me for this explainer.